Good evening and welcome to MDFA's Macular Month webinar for 2024, Navigating Mental Health Challenges in Macular Disease. My name is Mira and I'm an optometrist and healthcare relations manager with the MDFA. Before we begin, in the spirit of reconciliation, the MDFA acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Firstly, some housekeeping. All attendee cameras and microphones have been turned off. If you have any questions, please enter them via the Q&A icon at the bottom of your screen. Your questions will be answered at the end of the presentation, but feel free to type them out at any time. The webinar today has been accredited by Optometry Australia for 1 clinical CPD hour. So in today's webinar, we are pivoting away from our typical clinical focus on macular disease and imaging to highlight the importance of practical and psychosocial support for our patients and thinking about their lives beyond our clinic room. Tonight, we are delighted to be joined by two presenters, Dr. Sheila Kumaran and Rowan Goyne. Our first speaker, Dr. Kumaran, is a health systems and outcomes researcher at the School of Optometry and Vision Science, UNSW Sydney, with undergraduate and postgraduate degrees in optometry and a PhD in public health. Her research primarily focuses on patient perspectives of quality of life impacts of various eye conditions and its real-world implications. In partnership with MDFA, she is currently investigating the impacts of macular disease on quality of life and developing other programs of research in diverse areas of dual sensory loss and concussion. She's published her research in several peer-reviewed journals and presented in many national and international conferences. Sheila is also a mental health first aider and is accredited by Mental Health First Aid Australia. So to kick us off, please welcome our first presenter, Dr. Sheila Kumaran.
Thank you, Mira, for the introduction. I'll just share my screen. So hello, everyone. I really want to thank NDFA for this opportunity today to present on this very important topic of mental health. And I thank every one of you for attending this evening. I was wondering where to start when I started putting together my slides. I understand the audience today is eye care practitioners, and you don't need an introduction to macular disease, AMD, or its global burden. So let me dwell directly into the patient's perspectives of quality of life impacts caused by macular disease, particularly AMD, as reported by several qualitative studies. As you can see on the slide, multiple domains of quality of life are impacted by macular disease. However, often clinicians focus on the symptoms and activity limitations and are less aware of the other implications. On the right-hand side of this slide, you can see published direct quotations from patients signifying important, like concerns, social and emotional impacts as a result of their eye condition. These are often overlooked or not recognized in clinical practice, as the focus is often on improving physical function. However, in the research world, there has been considerable focus on the psychological impacts of macular disease, in particularly AMD, and studies have established a clear link between vision loss, mental well-being, and overall quality of life too. In today's presentation, I'll give you some insights into this area and hope the presentation will challenge you. Let's start with the definitions. The WHO defines mental health as a state of mental well-being that enables people to cope with the stresses of life, realize their abilities to work productively, and contribute to the community. Mental health is a basic human right. It is important that we understand that mental health is more than the absence of mental disorders. It exists on a complex continuum experienced differently by different individuals. Any departure from mental health constitutes a mental health problem. Mental health problem is a broader term that includes both mental illnesses and symptoms of mental illness that are not severe enough to warrant a diagnosis. So in today's presentation, when I talk about mental health challenges, I'm not just focusing on the diagnosed mental health disorders, but on the whole spectrum of mental health ranging from mild to more severe impacts. Depression and anxiety are the top two mental health conditions in Australian general population aged 16 to 85 years. Mental illness have major impact on disability, and experts rate them as one of the most disabling conditions alongside chronic physical health conditions such as cardiovascular disease or cancer. When I say disability, disability refers to the amount of disruption a health problem can cause to a person's ability to work, look after themselves, or carry out relationships with families and friends. Studies have shown that disability caused by moderate depression is comparable to the impact caused by relapsing multiple sclerosis, severe asthma, or chronic hepatitis B. So how common are depression and anxiety? On the slide, you can see the range of prevalence estimates from literature for depression and subthreshold depressive symptoms and anxiety symptoms in older adults with vision loss. There is evidence that the prevalence of depression and anxiety symptoms are further elevated in people with macular disease, particularly AMD. In a recent study conducted by UNSW in partnership with MDFA, we found that 16% of those with macular disease had depressive symptoms and 21% had symptoms of anxiety. Depression has been reported in both wet and dry AMD types, and there is some evidence of associations between AMD severity, the degree of vision impairment, and the severity of depressive symptoms. It is estimated that 30% of patients develop a depressive disorder within a few months of acquiring AMD in the second eye. Now, talking about anxiety, agoraphobia and social phobia are the most prevalent anxiety disorders in this population. Agoraphobia refers to the fear of being in open places or in situations where it is hard to escape or where help may not be available. Social phobia refers to the fear of being scrutinized or being judged while performing some kind of task in public. It is important that eye care practitioners are aware of these issues that the patients might face. Another major problem among older adults with vision loss is suicide and suicide ideation. On to your right, you can see a graph showing the suicide rates for older males in general population pooled across different studies. You can see how the rates increase with age up to 90 years. A recent study found that the prevalence of suicidal ideation among older people with vision loss was 32.5% during the COVID pandemic. This is substantially high compared to other estimates in general adult population, not just old population, any adult population with vision loss, which is around 9%. According to the ABS report, the most common psychosocial risk factor associated with suicide deaths in older adults was limitation of activities due to a disability, which you can expect in a person with vision loss. This was also consistently found in other studies that reported psychological strain and lack of social integration as risk factors. There is evidence that a vast majority of suicides in the Western world are completed by people who are diagnosed with at least one type of mental health disorder, including depression. I just wanted to highlight here that suicidal thoughts are not uncommon in this population, and it is important that eye care professionals are equipped to address this crisis by prompt, direct questioning and action. The relationship between vision impairment and mental health problems is complex. This is a model published in one recent paper on unmet needs of vision impairment and mental health. As you can see, sorry for the small font, as you can see, the mental health problems in people with vision loss can be mediated by several factors such as self-perception of vision loss, socio-demographic factors, distress caused by the vision impairment, functional limitations, treatment availability and its effects, and other health behaviors. Several other factors also contribute to depression and anxiety. In the 2023 MBFA Social Impact Study, we investigated loneliness, social isolation, sleep quality, and fear of falling. We found that more than 20% of our population were lonely and socially isolated. 43% had poor or fair sleep quality, and 72% had moderate or high concern of falling. In a multivariable analysis, we found that all these factors were associated with increased odds of depressive or anxiety symptoms. Vision impairment is also associated with increased risk of both dementia and cognitive impairments in older adults. Presence of more than one physical or mental comorbidities are also not common in older people with vision loss. In fact, a cross-sectional study in Scotland found that people with vision impairment are twice as likely to have 5 or more physical or mental health comorbidities than normally cited peers. In that study, they also found that vision impairment was associated with 27 out of the 29 physical health conditions that you can see on the slide, and 8 out of the 8 mental health conditions that you can see here. Depression, both major depressive disorder as well as depressive symptoms in AMD poses a serious problem. The disablement process shown in the slide here is a very simplistic model, but it helps to get the idea across. As you can see, AMD can cause vision impairment, vision loss, which in turn lead to functional limitations, example, difficulty reading, which contributes to disability, example, managing finances. On the other hand, depression can also have disability on its own, and studies have shown that it increases the odds of functional impairment independent of vision. Thus, in a person with AMD and comorbid depressive disorder, 2 pathways are in action, compounding the effects of disability. So just to summarize what I have said so far in all these slides, older people with macular disease may have a lot going on with many factors contributing to mental health problems and disability. And it is important that eye care practitioners recognize these. Although research has consistently demonstrated that there is a high prevalence of mental health problems in people with vision loss, depression in visually impaired persons is underdiagnosed and the uptake of mental health services is often low. In the general population in Australia, the National Survey of Mental Health and Wellbeing found that 65% of those with common mental illness did not seek professional help in the last year. This is not different to those with macular disease. Our MDFA social impact study found that 56% who screened positive for depression and 50% who screened positive for severe or moderate anxiety had not received any mental health support in the past. Another study in people with wet AMD found that up to 91% of those with clinically significant anxiety or depressive symptoms did not receive treatment for these mental health issues. Here you can see that there is a huge gap in this area that eye care professionals can aid to bridge. So how can eye care professionals best address depression and anxiety in people with AMD? International guidelines from the American Academy of Ophthalmology, the American Optometry Association, and the NICE all recommend that depression screening and management be implemented in healthcare settings for people at high risk of depression. But despite these guidelines, screening is not commonly done in routine clinical practice, leading to people unreasonably suffering from mental health problems that could be prevented or managed. Several barriers, patient-related and practitioner-related, exist in recognizing and discussing mental health problems in eye care setting. Both patient and practitioners are often focused on the physical aspect of vision loss and support in that respect. Even if symptoms of depression or anxiety was present, patients may attribute it to something else or think it is just normal to feel that way because of aging and vision loss. They also feel stigma and vulnerability to discuss these problems openly. Some perceive that eye care professionals didn't have the skill or the ability to help them with these issues. Other barriers identified from the patient side were related to lack of awareness of available support, difficulty accessing support due to mobility and other limitations, and reliance on personal resources. On the practitioner side, lack of confidence in mental health screening, fear of doing more harm than good by doing a screening, negative emotions anticipated during mental health conversations, lack of training, time constraints, and lack of awareness of referral pathways and support. And finally, patients' reluctance was identified as barriers. I think the first step in overcoming these barriers is just identifying them and acknowledging them. Being aware of these background information and having an open mind can help you have a productive mental health conversation with your patient. As always, start with your observations. Are there any signs of mental health problems evident in your patient? A person who is depressed can be slow in moving and thinking, can be less responsive, can show less interest, or look sad. If he or she is your returning patient, think if you see any differences in behavior and their outlook. During your conversation with them, look out for words such as worry, guilt, sadness, symptoms of fatigue, or other symptoms. You can start mental health conversation by paraphrasing the participants' own words, telling them what they just told you. Approach them with their concerns and listen non-judgmentally. You can ask specific questions on how vision loss is affecting their life and if they're worried about anything. This can actually give you a chance to administer a quick screening tool that I'll be talking a bit later. It is important to destigmatize mental health problems and provide reassurance. Let your patient know that depression is common and understandable reaction to vision loss, and explain that treatments and supports are available for mental health problems. When you identify a person has positive screening for depression or anxiety, initiate referral to general practitioners and provide information on support services. Having mental health conversations can sometimes be tricky, and training could help. For instance, there is this mental health first aid training offered by Mental Health First Aid Australia. And there are other trainings available too, and I would encourage you to look at them. So here on the slide, you can see some of the common depressive symptoms. For a person to be diagnosed with a major depressive disorder, they should be experiencing 5 or more of the following symptoms, including at least 2 of the first 2, nearly every day for at least 2 weeks. So there are several components in order to diagnose a person with major depressive disorder. Subthreshold depression is clinically significant depressive symptoms that do not meet this criteria for a depressive disorder. Both these types of depression are common in people with age-related macular degeneration. It is actually beyond the scope of eye care practitioners to diagnose depression, but we may be able to recognize clusters of symptoms which may indicate a person is experiencing some amount of depression. Similarly, these are some of the signs and symptoms of anxiety that eye care practitioners should be aware of. Now, whom should you screen? It is not possible to predict mental health problems based on visual acuity or disease stage. In fact, subjective perceptions of visual impairment rather than objective measures such as visual acuity are more strongly correlated with mental health problems. Patients who report functional vision are 90% more likely to be depressed than patients who do not report such problems independent of visual acuity. Thus, the recommendation here is to screen everyone with macular disease or AMD. So in the slide, I present to you a short screening tool called the Patient Health Questionnaire for PHQ-4, which is an ultra-brief screening tool that has 2 questions on anxiety and 2 questions on depression. It is a very simple tool that asks, over the last 2 weeks, how often have you been bothered by the following problems? Feeling nervous, anxious, or on edge, not being able to stop or control worrying, little interest or pleasure in doing things, feeling down, depressed, or hopeless. It has 4 response categories, not at all, several days, more than half of the days, and nearly every day. For both anxiety and depression subscale, the cutoff score is 3. If the total score is 3 or greater than 3 on either subscale, you should refer the patient to a general practitioner for further evaluation and provide the person with a list of support services. So the general practitioner or the mental health professional that you're referring the patient to would probably follow the positive screening on the anxiety subscale with another, like a long scale, like the generalized anxiety disorder scale. And if there is a positive screening on depression, they would follow it up with a patient health questionnaire 9 scale, which is a longer scale to assess depressive symptoms. So the PHQ-4 is a very short, reliable, easy tool and has been used in several studies and has found to have good sensitivity and specificity in order to identify depression and anxiety. Please remember that the tool itself is not a diagnostic tool. It's just for screening purposes, and it will take less than 2 minutes of your time to administer it. So for your information, this is the generalized anxiety disorder scale that I was talking about. The anxiety subscale of the PHQ-4 that I showed you in the previous slide. The first 2 questions of the PHQ-4 is the first 2 questions of the GAD-7 scale. The scale has a total of 7 questions and can be used to further assess the severity of anxiety by mental health professionals or GPs. And this is the patient health questionnaire 9 scale that I was talking about. So the depression subscale of the PHQ-4 is the 2 questions, the first 2 questions of the PHQ-9. So this scale has 9 questions and helps to assess the severity of depressive symptoms. Contradictory to perceived barriers, experiences and attitudes of older people to mental health screening in eye care and vision rehabilitation services was positive. According to the study in Australia, which used the PHQ-2 depression screening, majority of the patients thought mental health screening was a good idea and it was easy to answer the screening questionnaire. The patients did not feel embarrassed, upset, uncomfortable, or annoyed answering the question. This is actually very encouraging and promising for eye care practitioners to take the step and do the screening. Finally, support is available for people with macular disease and vision loss. MDFA offers free support for people with macular disease. Their programs include Eye Connect, MacMates, and peer support groups. I'll let Mira and Vicky talk about that. These programs are available in person, over the telephone, and online, and are excellent opportunities for people with macular disease to stay connected and be socially active, which are really important for mental well-being. Another very useful resource is the one put together by Vision 2020 Australia Mental Wellbeing Group. The Mental Wellbeing Resources Guide compiles services and supports that are available for people with vision loss. It provides a list of resources for both crisis and voluntary support, and it is categorized according to the evidence-based stepped care model to deliver mental health programs. It is a really useful guide, and it has resources from organizations associated with eye care service delivery as well as low vision rehabilitation. Plus, it has other options offered by mainstream mental health services. So in a nutshell, there are paramount evidence about how common mental health issues are in older people, especially in those with AMD. Holistic care should focus both on physical and mental well-being. Eye care practitioners are well positioned to identify mental health problems even as they are emerging at a very early stage. Recognizing mental health problems at a very early stage is important because it puts people at risk for developing major mental illnesses later in life. Although barriers exist to mental health screening, these could be overcome with training and practice. Having a mental health conversation and spending 2 minutes of your chair time to do a quick screening for depression and anxiety using the PHQ-4 in this high-risk population will go a long way. Mental health support is available, like I mentioned. Great support is available through MDFA and also the resource list from Mission 2020 Australia. But we should work together to increase awareness and reduce stigma and enable people in need to access it. So, so that's my message for you guys today, and thank you very much for listening.
Thank you, Sheila. That was a fantastic presentation on such an important topic for our patients. Just a reminder for anyone with any questions that you can post them in the Q&A now, and we'll come to them at the end. So I'll just introduce myself. My name is Vicky Heaton. I also work at MDFA. I'm in the research and advocacy team, and I'm also a practicing optometrist. So I really got a lot out of that presentation from Sheila there, and there's lots of things that we'll be able to implement. I'd like to introduce our next speaker, who's going to join us from Canberra tonight, and he will be talking about his experience living with AMD. So Rowan Goyne is admitted to legal practice as a barrister and solicitor in the High Court of Australia, the Federal Courts of Australia, and the ACT Supreme Court. During his legal career, he held senior legal positions in the Australian and ACT Public Services, and was also a Chief of Staff and Senior Policy Advisor to the ACT Attorney General and several key ministers, including the Minister of Health. Rowan established his own legal practice, and since semi-retiring from his legal career, has become a historian and author. He has had over 60 articles published in international and national historical journals. Rowan is a fifth-generation Canberran, and he lives there with his partner and 2 adult daughters. He was diagnosed with wet or neovascular AMD in 2014, and he's been a member of our MDFA community reference group since February 2023. So welcome, Rowan, and thank you for joining us. I'll start with the first question. You were diagnosed at quite a young age. Can you tell us about your experience? Because I can imagine it came as quite a shock.
Yeah, thanks, Vicky. Yeah, I was diagnosed at the age of 47. I'd just gone to my optometrist, my regular eye check, and he did some optical tomography, digital photographs, and he picked up an anomaly in the macula in my right eye, and quickly wrote a referral to a local ophthalmologist here. I then rang the ophthalmologist surgery and was told to come over straight away, which I thought was a bit concerning. I did come over straight away. They then did some further tests, and then I was ushered into the specialist room and announced that I had macular degeneration and that I was about to be receive an intravenous injection into my eyeball to save my sight. So that quickly followed. This was all done in the ophthalmologist rooms. And probably half an hour later, there I was contemplating life with now wet macular degeneration in one eye and having had the intravenous injection, which then was Leventis. It was pretty, I was pretty shocked. I must have been pretty shocked following the treatment. I went back to work and sat at my desk at work. I held a fairly senior position then in the Australian Public Service in the legal field, and thought, well, what does this all mean? I must admit I didn't get much information from the ophthalmologist other than it was an emergency and we had to save your eyesight. We had to save your potential loss of your eyesight, which apparently could have occurred at any time in one eye. And the reason they diagnosed that I got it was I'd had anabolic steroid treatment for an autoimmune disease, 20 years before that, for over 12 months. And so, of course, antibiotics, that accelerates everything you're going to get in your life. So that was the reason ultimately advanced as to why I had macular degeneration in one eye and I was below the age profile for it, being a male. So that being said, well, I had a fairly intense job that was predominantly computer-based, advising a major national cultural institution in the digital space with respect to all of its legal obligations, also all of its procurements that it was doing, and generally keeping them legally on the right side of the line, despite the efforts of some of the staff who were blundering around, basically. So I was the one-eyed man in the kingdom of the blind, legally. So I was left with really sitting at my desk and then working out, well, where do I go and where do I get information about what I've just been told I had? So I went to the MDFA website. I contacted the MDFA, phoned up, got myself put on their newsletter list. I also contacted Vision Australia because Vision Australia have practical aids. They do the testing for you to determine the extent of your vision loss, and I'd lost about 30% of the vision in my right eye. Also lost my depth perception. So I was in constant challenges with trip hazards, which was something that, I wouldn't have cared about or worried about previously, being fairly agile. So suddenly I became disabled in all senses of the word. Through work, to continue to work in the capacity I was doing, I accessed the Job Access program, which is a government program to facilitate people having the necessary equipment to continue in their job rather than going off onto a disability pension. So that was
Rowan, can you tell us how you found out about those services? Was that through Vision Australia?
That was through my HR service. They had a disability support officer. That was their process. Our Job Access was they sent an independent assessment, someone to come and do an independent assessment in my workplace, because I needed, and it was assessed that I needed a reader. I needed additional lighting that wasn't provided in my office. I needed Zoom tech programs for the computer, etc. And so through Job Access, that was a process that took 2 to 3 months in total. Then work paid for the equipment. Again, there's another 4 weeks for the equipment to turn up. The assessor comes back and sets it all up in your office, and then you can resume effectively working in the role that I was doing. Without it, I was fairly hampered and I realised that's what was affecting me, diminishing my ability to contribute just simply because I had a low vision. Now, look, I was advised by the head of HR probably not to disclose a disability, because that basically leaves you being marked, unfortunately. But I chose to because I've always believed that I need to be upfront with my employer. But you know, there's consequences to that. That's just general. The world is an able-bodied, full-sighted world. It's not a world designed for people with, in my case, a low vision impairment. It's far from that, and so it's it's a case of you do it at your own risk, knowing full well what the consequences are. Look, you know, I had training with a cane. I was subjected to abuse by people because I didn't present as being blind, and so why would I have a cane? Obviously, I had a cane because of my, for example, loss of my centre of balance, and the cane was there to tap to identify edges and surfaces that my sight wasn't telling my brain, hence adjusting my foot position, which I'd naturally lost because of the macular degeneration. I've got issues with glare in early mornings and also in shadow, seeing definition. So I need extra lighting that's separate from to light things so I can see. I need things that on a computer sense that have to be a certain font size and certain colours. And you know, we have this debate, and I've had this debate with my equipment turning up on the desk, and then others in the agency deciding that they needed the same equipment because I must be being favoured because I've got all these machines that go ping. And sitting on my desk, and then, you know, so you experience the latent ignorance, and I call it blissful ignorance or willful ignorance of the sighted in relation to the low vision. Of course, the agency itself benefited from a couple of hours of training provided by Vision Australia through my job access package. And they suddenly discovered that, I don't know, 40% of their workforce had low vision issues of one description or another. So that was a bit of an eye-opener for them. You know, that again reflects poorly on an agency. And then we're talking about public sector, a significant public sector agency here in the Australian Public Service, where you would expect better and you would expect better processes and sort of like. Anyway, look, I left that job and I decided that what I really needed to do was be my own boss again. So I took what was a hobby, which I'd been writing military history for about a decade. I turned that into my occupation, as it were, and I now do that full time in a whole variety of ways. I work with professional military historians and space historians, and in collaborative mode on a whole variety of things. My comments are sought by the ABC and local radio here in Canberra on military issues. I also and in Radio 702 ABC in Sydney. So I've sort of established a fair reputation for someone who's competent in the space. And my stuff is, I used to write in the obscure. What I've written about now is no longer obscure. It's now apparently it's more mainstream. And hence why I'm contacted by academic historians from overseas institutions like King's College in London and Cambridge University. And some of my stuff featured on a Dan Snow documentary during COVID, one of his blogs. So it
sounds like you've coped remarkably well, you know, through all this time, because you've had this for quite a long time. How would you say that you've sort of, because I know you're already a little bit Rowan, but yeah, can you tell us a little bit about how your experiences with, you know, with a little bit with your mental health or your well-being through this period? Because I know you're a very resilient person, but if you could just tell us a little bit about your sort of strategies and how you've coped. Well,
part of that's keeping myself busy, and always looking for the next thing. So I keep myself mentally stimulated in a whole way, shape and form through a number of other hobbies that I pursue. And it's really about relying on your networks. So I've got, as I've left the permanent workforce, I've got a network of friends that I sort of chew the fat with on a variety of things and reach out to on things. So you never want to make yourself isolated. You always want to involve yourself, and that brings its own rewards. It also brings, criticism. I've had criticism of my work by certain people who decide that they don't agree with the viewpoint I put forward. Well, that's all very well and good. My theory in relation to history, it's all about a debate, and it's all about the good, the bad, and the ugly. And there's good, the bad, and the ugly in every element in our historical background. So that's the way I pursue things, and I don't let the negativity, and there's a bit of it, I don't let that bother me particularly. I just think, well, that's your problem. You go and sort it out yourself.
Yeah.
And I can be fairly blunt with people too if I have to be.
Do you have a group of people, or do you have any sort of people going through a similar situation as yourself that you can
no,
with, or are you mainly?
No, I must admit I don't have other people that have gone through the vision loss that I've gone through. They're always people of my age. It's generally about, they're talking about their parents that are undergoing the treatment, and people will admit to that. But very few people my age. I mean, I'm 57 now, so I'm getting on a bit. But no, very few in my, and I've had that. My mother used to drive me to the appointments because you can't drive afterwards, and they'd say, "Oh, he's very young, isn't he?" And that was because the other people in the waiting room are probably 75 and over.
Yeah.
So, I mean, that's sort of, I very rarely confront a younger person in the waiting room for the ophthalmologist for my right eye that I go to. It's a challenge is the cost, obviously. That's a very great challenge. And I've had to negotiate with my ophthalmologist after spending in the first 18 months where I was having an injection, firstly every couple of weeks and then every month. After 18 months, I'd spent $25,000 up front, a $1,200 cost every time you had it with this particular ophthalmologist. And I had to say up front to him, I said, well, I can't go on continuing to pay this to you. I'll either have to go on your public list in the hospital, or we need to come to some agreement. And a bit of toing and froing, we came to an agreement, which allows me to continue to see him in his rooms. And he no longer has a public list because of the challenges he was facing with the public hospital system. And he and I are friends almost now. I have coffee with him occasionally, and we took, because I'm on the customer reference group for the MDFA, we talk about the from a clinical perspective, from his perspective, the treatments and the like, which improves my ability to contribute on the customer reference group.
Absolutely. And looking back now, what sort of things and what supports would you have benefited at the time when you were diagnosed all those years ago, or to live, those first few years after you were diagnosed with AMD? What would you have needed or liked to have had to have dealt with it?
Look, obviously maybe a peer support group or something like that, but there'd be very few people in my circumstance that would have been diagnosed with it, as I've explained. But certainly more information than I received. I didn't really receive any information. I was left to, and that was probably the crisis that they found themselves in relation to me. Really I was left to work it out myself, and I did that with with the support of MDFA and Vision Australia, I've drawn on that. So I'm always a believer in, and that's just the legal training is you do the research to understand, because I was faced with and I ultimately have accepted this, that I will eventually be blind in one eye at least. Whether it spreads to the other eye, well, that's neither here nor there. I mean, I was on Leventis, and my body rejected Leventis, so that set me back right to the beginning again. And luckily, the Eylea was available, which I'm now on, and I've been on Eylea now for 5 years. So if Eylea hadn't been available, I would have not had a mainstream treatment for the wet macular degeneration, and then it probably likely I would have lost the sight in the macula in the right eye, and then everything that goes with that. And it's the cost too. There's a enormous cost burden that people don't really recognise. I'm not legally blind, so I don't qualify for NDIS or anything like that. So that's, so I bear all of that. I have to budget and cash manage that within my resources for the equipment's expensive. There might be a new U-Butte reader available, or pair of glasses or something like that, digital glasses. Well, if they're thousands of dollars, well, unless I get on a trial for them, I can't be purchasing them up front, to be brutally honest. It's just, so there's a disability tariff that people in my situation bear, and it's not tax deductible. There's no assistance anywhere. You've just got to cash manage it. And I'm in a fortunate position I can do that. But as I said, I had to negotiate the upfront fee, and that was a humbling experience. But I was acting on advice from NDFA in that regard. So you've got to, my ophthalmologist could have said, no, sorry, I charge what I charge, and if you can't afford it, go elsewhere. And then I don't know where that would have left me, but yeah. So it's a constant challenge, and just the physical environment. I find myself lobbying now for the physical environment around simple things like reflective markings on stairs and guttering and things like that, because they're basic aids that I need and others in my situation need to safely participate in society and access things. I've had a bit of luck recently in relation to that local football stadium and Macular Oval with the international crickets here. I've been lobbying and I've successfully lobbied to have all the reflective markings put on all the surfaces in both locations.
Oh, fantastic.
That's a minor victory, but I go to both those locations.
Yeah.
I was only at the Raiders game on Saturday night, Saturday afternoon, and there were my reflective markers.
Very good.
Where they hadn't been before. So you've got to learn to be an advocate for yourself and for everyone else in the space, and that's partly my training too, from a political role in the past. So I bring all that to bear and to some effect. But there's so much to do, and there's not enough time to do it all in.
Well, we very much appreciate you being a part of MDFA's community reference group, because that's also obviously something that we, strongly advocate for, is for, improvements to people's lives with people with AMD and any kind of macular disease. And thank you very much for joining us this evening, Rowan. We really, really appreciate you jumping on and sharing all those experiences with us. I'm going to hand back over to Mira, and then we'll come to the Q&As at the end. Thank you, Rowan.
Thanks, Vicky. And thank you so much to Sheila and Rowan, really, for sharing your knowledge, expertise and experience tonight. I would just like to remind you all that we do welcome your questions. I can see that quite a few have come through in the Q&A box, and invite you to enter those into the Q&A box while I give a quick MDFA update that's relevant to you as health professionals. So in a very exciting update, I'd like to let you all know about MDFA's newest patient support service for people living with macular disease. As Sheila and Rowan have mentioned, receiving a macular disease diagnosis can be an anxious, frustrating and isolating time for patients. And once they leave your clinic and care, they need to navigate the condition on their own. So this is where a robust, tailored patient support service comes in. MDFA's new service is designed to provide patients with personalised guidance and tailored support based on their disease type, vision status and emotional wellbeing state. So this information will be provided over an extended period, enabling them to better understand and manage life with macular disease. The service will provide 3 main avenues of support through phone, email, and hard copy. And these support areas centre around providing disease information, practical support, and importantly, psychosocial support too. You can refer your patients via Macular or via our website e-referral form. Patients can also self-refer via the website. You can also email us for a copy of referral pads for your practice. And finally, as healthcare professionals, MDFA are keen to support your work. For those of you who have an interest in eye disease, you can subscribe to Macular Matters, which is our quarterly e-newsletter, a quick read and update of what's happening in the macular disease sector. We also have free CPD accredited courses for various health professionals available via our website. So I'm now going to invite Sheila and Rowan back to answer your questions. And I'll just bring up the questions here. So there's quite a few coming through about managing mental health with patients presenting in clinic. So Sheila, I think a couple of the first ones are directed towards you. The first one is, would you recommend healthcare professionals do the mental health first aid course?
I would definitely. Personally, I found it like really enlightening and just improved my confidence a lot. And I definitely understand. I can relate to a lot of comments, questions there. I acknowledge that it can be tricky to have those conversations. So having some training in this area would really be helpful.
Great. And then there's a few similar questions.
I'm happy to go through it one by one if you like.
Yeah, that'd be great.
That would work. Yeah. So second question is, what do you suggest we do if a patient presents and is very anxious? Yeah. So I think the important thing is to understand the reason for anxiety, like is there a new diagnosis, what they are anxious about. But sometimes there may not be any reason for anxiety in that case, like you really don't know the root cause to address it. So it could be either way, but yeah, so in the mental health first aid training, they always teach you to go through the the acronym ALGE, which is approach, listen, non-judgmentally, and encourage support and other services. In this case, I think like I mentioned, lots of support is available through MBFA, and the peer support and information available could ease some of the anxiety. So I would recommend getting access to the support. And if you're able to if you're able to refer them to a more detailed evaluation with the GP, or talk to some mental health professional, just that would be very helpful too. So I don't feel confident talking about mental health. Yeah, I think I have answered that question. We all lack confidence sometimes, and definitely some training like mental health first aid could really be helpful. How do you suggest I start conversation with mental health? I think some of them I addressed in the slide. I think we could start from what we hear from the patient, like during the history, when the patient is having a conversation with you, you find out, you hear words of worry, anxiety, nervousness, or, words that stand out. So you could start the conversation paraphrasing just what the patient actually told you, and tell them, I hear this, you said this, you mentioned this, and then move on to more, specific questions, asking how the, the eye condition or vision loss is affecting them. Also, I think it's, do I need to ask permission to use the screening tool? I think we need to tell them that we would, it's good to use a screening tool, a quick screening tool to, know the intensity of the symptoms that they are facing. And like I mentioned, there are perceived barriers, but people are kind of like open to using screening tools. Our service is available to patients in aged care facilities, the MDFA services and Vision 2020. Do you want to answer that, Mira?
Yeah, absolutely. So we offer all our services to patients regardless of where they live. So we can definitely offer these services to people living in aged care. So they will just need to be referred to the MDFA. So that can be done via our website. That can be done by a carer or a family member. And then we will get in contact with the patient to offer them the various support options. So we do have peer support that is available virtually. And also over the phone. So if they can't physically make a peer support group in person, there are other options available.
Yeah.
So I think the next question, Rowan, is for you. Hi, Rowan. Did you receive?
Sorry, Mira. There was this question on suicidal thoughts. I might have made.
Yeah, sure. Okay.
So I think that's a very important question. And if a person is sharing, like thoughts of suicide, I think the recommendation is to directly ask the person whether they're thinking of suicide or whether they're thinking of, like taking their life. So that's the direct probing that's recommended. And if there is, if the person acknowledges that they've been thinking about it, I think the next thing is to assess if there is a plan in mind that they have in mind. I think, like if you're doing a mental health first aid training, they will teach you how to do this, like professionally. But I'm just giving you like a basic insight. So ask them directly whether if they have thoughts of suicide, and ask them if they have a plan. And if they have a plan, what's the plan? And if they don't have a plan, like you have to make sure that some safety process is in place to make sure the person is safety. You have to come up with a safety plan. And also, like, you have to definitely encourage the person to contact the mental health crisis like number. There are like local state specific mental health crisis number, but there's also national mental health crisis number. And if the person is reluctant to seek help, I think it's also, like you could offer to call the mental health crisis number together with them. And like inform other people in the family, or with their permission, that that about the situation. I think that's important.
Thanks, Sheila. So the next one is, Rowan, did you receive much information about your condition from your eye specialist?
No, at the time when I went to the initial appointment, I didn't receive any real information other than that you've got wet macular degeneration and we're about to treat you. So that was the extent of that. As I said, I had to go away and work out what it meant for me, seek whatever advice I could find and what was available. Frankly, it was a bit of a journey. You do the journey yourself. Effectively, that's my experience anyway.
Thanks, Rowan. We had a question about what condition, Rowan, you had that you ended up with early AMD. So I believe that was,
Yeah, that was from Sue Harvey, I see here.
Yes.
Look, that was very much a speculative guess, best guess done by the ophthalmologist, by having looked at my medical history, and then he reached the conclusion it must have been my anabolic steroid treatment, which went on for about 9 months for a separate autoimmune disease 20 years previously. So that the anabolic steroid accelerates everything in medically you're going to have in your life. So that's effectively, he was grasping for answers, I think, because I was seeking some. Anyway.
Great, thanks. So the next one is, can MDFA offer support for regional patients? And absolutely, as I mentioned before, so it doesn't matter where the patient lives. We have resources that we can send digitally, via email, phone, or also in hard copy as well. So we are based in Sydney, but we offer national services. Rowan, did you go back to the optometrist to discuss what had just happened at the ophthalmologist? And did you get to see any of the reports that went back?
No, I didn't go back to the optometrist. No, because the next week I had to be back with the ophthalmologist having another needle stuck in my eye. That went on for 4 weeks, every week for 4 weeks. So I was back with the ophthalmologist again, and then really it's having the treatment, and then takes you several days to recover from the treatment. So that was a bit of a treadmill for the first 4 to 6 weeks before the spacing moved out to once every 2 weeks. So it's a case of try it and see. It's not a pleasant experience. It's not something I'd wish upon anybody, and I still to this day dread when my next appointment's in a couple of weeks' time having it, and I'm out to like 14, 16 weeks now between treatments. So it's not something I wouldn't wish it upon anybody. It's very unpleasant. Very unpleasant.
Thanks, Rowan. We're nearly out of time. We are out of time, but we have 2 more quick questions for you. Thank you for sharing your journey with us. Looking back to the date of diagnosis, what information would you have appreciated from the optometrist or ophthalmologist to really tell you more?
Probably MDFA's website address might have helped. Yeah, that might have helped. And the last question is, if my other eye is still well sighted and if I'm treated and it's not like do you still feel sick? Well, in my other eye, I got shingles in my other eye 4 years ago, and now I'm treated for, and I still have the residual virus and scarring on my eye. Almost lost the sight in my left eye as a result of shingles. Again, that's just wasn't my fault. It's just reoccurred. So I now have 2 ophthalmologists, one for each eye, one for the back of the eye, one for the front of the eye from different eyes. I've lost 30% of my vision in my left eye, in my right eye. My depth perception is lost, and I've lost a lot of my peripheral vision in the right eye. So I feel that the definition of legally blind to qualify for a lot of things needs to be changed quite significantly, because it's not appreciated. Well, the government deliberately doesn't want to appreciate it because it would open up the payment of benefits to hundreds of thousands of more people.
Alrighty. Thanks to both Sheila and Rowan for your time today. They've been really insightful presentations, and I hope everyone's taken away something from this webinar. For those of you who have found this webinar useful, I encourage you to complete our free and accredited courses through the MDFA, and also really encourage you to refer your AMD and macular disease patients to the MDFA for support. So many thanks again, and good night, everyone.